All right, so thank you for inviting me to talk to you about blood pressure management. I feel like since we've had a few cases that rose some questions about how we could select better our agents to lower the blood pressure or elevate the blood pressure, which vasoactive meds to use, and in which, at what rate in what peripheral IV versus central line. I felt like talking about blood pressure targets and blood pressure management in general, whether it's lowering it or elevating it, was maybe judicious at this time of the year. And we'll cover also a dedicated maybe stroke education and a debate with our vascular neurologists and interventionalists about setting standards for goal blood pressure in hemorrhagic and ischemic stroke. But here this will be a broader topic. So just to talk about blood pressure in general, what are the targets in neurocritical care? Maybe I'll insert also a reference to, I think, a review in the literature that was done even a few years ago, but nothing has changed much in terms of the targets or the general concepts. I think by Stefan Meyer, and I think the title was about what you see on that slide, the general blood pressure targets in neurocritical care. Obviously, diseases are very important, whether we're treating a hemorrhagic stroke or an ischemic stroke, you will have different targets. TBI, cardiac arrest, there's many different diseases that impose, of course, a different targets. But in general, the main concepts that has been even difficult for people to grasp, whether you're trained in vascular neurology, neurointerventional, or you're an anesthesiologist or a trauma surgical intensivist, you see it slightly differently because you not necessarily understand the difference between those two opposite goals. I would say that it's important to start by saying that the systolic blood pressure is what leads to shearing injuries, and therefore this is what the risk will be in terms of hemorrhagic expansion, hematomal expansion. By hemorrhagic versus hematoma, I just make the difference between a subarachnoid hemorrhage, an active hemorrhage into your parenchyma versus into your ventricular system. And once a hematoma really forms, the expansion is a little bit lower, but it can still occur. As you know, an intraparenchymal hematoma is still at risk of expanding during the first 6 to 12 hours. There's the perihematomal edema also that matters because it will trigger mass effect and neurological deficits. So beyond just the hemorrhage, also the systolic blood pressure will drive perihematomal edema expansion. And it can also lead to, as we know, oozing or worsening in the post-op surgical bed. Even just the capillaries, even if you don't have a vascular lesion and your hematoma is controlled, once you remove the hematoma or you remove a tumor, for whatever it's worth, the neurosurgeons on this in this audience can maybe give me some pictures that I can insert there, where we know as an anesthesiologist, you drop the blood pressure and you will see less oozing into the surgical bed. And finally, another thing that is bad with an elevated systolic blood pressure is that it's going to favor the suffusion of basically not the red blood cells, but the plasma will go into outside of the endovascular space into the parenchyma or the subarachnoid space. That will lead to cortical edema and subarachnoid hemorrhage or subarachnoid proteinaceous plasma extrusion, and that is even more so the case when the blood-brain barrier is open after a massive large infarction. So malignant infarction progression towards ICP elevation and subarachnoid hemorrhage, a reperfusion injury after a TK3, all those things will lead to a risk of edema or hemorrhage, and that should be decreased in terms of we can reduce the risk of that bad occurrence by reducing our goal of systolic blood pressure. So the upper limit of your target should always be a systolic blood pressure, not a MAP. Conversely, when you try to salvage somebody from a poor cerebral blood flow, you need to talk about MAP goals. It does not make sense to put a systolic goal to salvage somebody. Why? Because the map is what drives during the diastole the orthograde flow into the parenchyma and the capillaries, and therefore the cerebral blood flow that perfuses the brain is more closely related to the map rather than the systolic blood pressure. Or if you had to choose one, maybe the diastolic blood pressure would be mattering more. So ischemia and penumbral salvage are driven by the map augmentation. So ideally, we would put a goal or an order that says systolic below X and map above Y. And we should also think about the map when we are trying to put goals in terms of a TBI patient that has an elevated ICP, because as we know, the CPP is what drives the cerebral blood flow. Any questions on that? I want it to be interactive, by the way. If I say something that is not well understood, please pitch in now and I can go into more details.
No, just what I would add for obviously for the residents and the um, PAs that are on is that this is a very dynamic process, and increasing somebody's blood pressure may improve somebody's ICP if somebody has autoregulation intact and they have cerebral ischemia due to the low blood pressure that's causing then worsening edema. Increasing their blood pressure may actually help their ICP go down, even though their MAP is going up, because you're decreasing the cerebral ischemia and thereby decreasing the edema. If somebody has very poor autoregulation, meaning that their blood vessels are not constricting appropriately as somebody's blood pressure goes up, because that's what happens in the normal brain, then driving somebody's blood pressure up as it increases MAP may actually increase their ICP. So in two different patients, increasing somebody's blood pressure may do two totally different things. And it may do different things in the same patient depending upon what day you're talking about. You know, one day they might have poor autoregulation, and one day they might have good autoregulation. Even within the day, it can change sometimes. And it can also change depending on the location in the brain. So it's possible that increasing the blood pressure is helping decrease the cerebral ischemia in one part of the brain, but making the edema worse in another part of the brain because the autoregulation there is not intact. So it's a dynamic process over hours and days, and it's also dynamic within a given patient depending on the location in their brain as well.
Exactly. I think we had that, and maybe I'll insert that slide here too to further support what you just mentioned. But yeah, we've seen, I think, in other lectures the ICP regulation and how it goes up and then back down, and the vasodilatory cascade versus a vasoconstrictive phase. So yes. To keep it also simple, we need to have in mind that there should be a primary goal and a secondary goal. So I know soon we're going to talk about the orders and exactly what do we need to put, but I wanted to cover first conceptually what's going into our mind when we set goals and we put an order. Eventually, you cannot have a systolic and for the upper limit and a map for the lower limit. Unfortunately, pragmatically in EPIC, we need to put a single range using only one parameter. But it's very important, and that's a slide that comes from Camilo Gomez, notorious neurointerventionalist and stroke neurologist that just talked at the American Society of Neuroimaging and at the SVIN with Dr. Qureshi, and they were also saying those very important concept of setting a primary goal and a secondary goal. So when you have ischemic stroke and you are thinking about the perfusion, your primary goal should be a map augmentation, and the secondary goal is don't go too far up, because if you go with a systolic beyond 200, then you're going to be detrimental. Now, if your patient is reperfusing a little bit better, they're here talking about a score of a perfusion score of a 2, for instance, an IVTPA resulting in no clinical improvement, then they would have the primary goal be a little bit lower in their MAP augmentation, and they would also lower the systolic blood pressure upper limit to less than 180. By the way, those numbers here don't match exactly what I'm going to show you on the next slides, but I did reconcile with the Dr. Gomez and Qureshi, and I'll give you how they support my views. But here it's the concept that is of primary goal and secondary goal that is really important. And finally, when your perfusion is really resulting, for instance, at the very bottom of the slide here, you see resulting in optimal reperfusion, for instance, a TK3, then your primary concern is not ischemia, but it's more I'm reperfusing this guy too much, and therefore he's at risk of bleeding or having reperfusion injury with subarachnoid hemorrhage, and therefore my primary goal should be a systolic below 160, or actually they agree that sometimes it should be less than 140, with a secondary goal of a MAP augmentation, and actually they agree about a slightly lower MAP above 75 might suffice. But I'll get more in details about those actual numbers in the following slides. But here I wanted just to point out the fact that there's a primary goal and a secondary goal, and depending on are you talking about ischemia versus hemorrhage and how much risk of reperfusion injury there is, you should tweak those goals in your mind before you then enter the order in EPIC. So what are the targets in general in neurocritical care? Well, in acute ischemic stroke, if you are presenting and you're not getting any TPA or anything, the very upper limit, just to give you a broad stroke of how high can we go, the systolic blood pressure is never good, even in the setting of ischemia when the systolic is above 220. So that was a general mantra that still permeates in the recent AHA guidelines, that if you have an ischemic stroke, sure, you're going to have an automatic response and your body will generate hypertension to try to salvage yourself from the penumbra and the ischemia. However, if your systolic goes beyond 220, that could be deleterious. So even if you're trying to save your brain, a systolic above 220 is generally considered detrimental. Now, after a massive infarction also that is at risk of hemorrhagic transformation, even in acute ischemic stroke, we sometimes say the systolic should not go above 200, and we start gently treating maybe with a PRN, hydralazine or labetalol, a blood pressure above 200. As you know, if you're about to give TPA, you need to do a blood pressure less than 185, systolic below 185 before you deliver the TPA, because now you are doing something about the salvage. The reperfusion will probably occur thanks to your TPA, and therefore you also need to make sure there's no hemorrhagic transformation. So the guidelines are telling you your blood pressure needs to be steadily below 185 before you push the thrombolytic. If you are doing a reperfusion intervention that is endovascular, it's even below 180. And after the recanalization, whether you're TK2B or 3, usually it's less than 160. And depending on your collateral status and how much reperfusion and how much opening of the blood-brain barrier, I mean, we can go really fancy into advanced imaging and creating scoring systems, as Dr. Gomez and Qureshi just presented at the SVIN and ASN. But sometimes we go down even below 140. So a patient that is very well recanalized, and we have parenchymography showing, wow, there's really flow in the parenchyma a lot. And or we do TCDs and we're like, you know what, those collaterals are like robust. He's never gonna have ischemia again, and I'm even worried about him having too high of cerebral blood flow. Or you do TCDs and you have a TB, I think it's 5, meaning hyperperfusion, like you see the cerebral blood flow is through the roof because you recanalize or you stented a carotid, and now you have like too much cerebral blood flow, then a reduction below 140 is even justified. I could even add a line. Sometimes we say even less than 120 because of the very high risk of bleeding. Now, switching gear to ICH, historically the AHA guidelines were saying less than 160, and now I'm going to make my case for 120 to 140, even if I know that most templates use the target goal of 130 to 150. But I have a strong argument. I'm not going to make it today, but I'm going to make it to the stroke team in the near future for why actually everybody implied that 120 to 140 is the ideal target after an ICH in all comers. Now, we are sometimes saying, by the way, even higher than 150. We say 110 to 160 for when there is an ICP concern. If you have a huge intraparenchymal hematoma, or you have an intraventricular hemorrhage like we had recently, and we put an ICP monitor or an EVD, and you see that the ICP is above 20, then you do the math, and that's what Camilo Gomez just told me. Like, everybody's different, so we should have in mind a MAP goal, and if we have an ICP, then we should have a CPP goal in mind. Then you subtract those 15 or 20 points of ICP that they may have, and you set your MAP goal. So MAP is usually going to be MAP above 85, but systolic below 160. And how do you transform the MAP of 85 into a systolic range so that you know what is your lower limit? Well, it depends on each patient. So I really like that cue that Dr. Gomez and Qureshi gave me last week by saying, just enter the room, look at your map, do your math for the predicted ICP or the measured ICP if you have an ICP monitor, and transform that into whatever the systolic is for that very patient, because everybody's different. A map of 85 in me might mean a systolic above 100, but in an elderly, it might be a systolic above 110. So that is why we're coming up with this magic number of 110 to 160. It's because the 110 is a translation of a map above 85 for a CPP above 65. And we're putting the upper limit as what is the most conservative, which is basically 160. But an ICH all-comer in the parenchyma of moderate size, you can go with a goal of 120 to 140, and I'll go over a little bit of the arguments for that. Sorry, there's a typo here, but it's 15 to 20% reduction. When you have an ICH that is presenting in the ED with a systolic measured twice without intervention above 220, then and even more so if you ask the family member, does he run that high when he's at home? And they tell you, yeah, sometimes he's 180, 200 at home. If you hear that the patient is ranging really high and now they're presenting with two numbers above 220, I would say that indeed we need to follow what the prior AHA guidelines were telling you, which is a reduction of 15 to 20% of the systolic blood pressure is preferred over a more aggressive, what is called early intensive blood pressure lowering strategy towards this less than 140. So less than 140 can be detrimental to an ICH that is presenting with a huge size. The past medical history tells you, yeah, he's been running high at home, and now you're in the ED in the rack, the resuscitation room, and you see the systolic above 220. Then you should do the math of a 20% reduction instead of targeting 140. Anybody wants to pitch in on that? And don't worry, I'll show you some epic order sets that we're coming up with, and also the exact range. It should always be with a lower range and an upper range because it's an actionable range in the ICU. Even if the vascular neurologist or interventionalist tells you I prefer to say less than X, you cannot do that in an ICU. You need a lower range so that we know when we're gonna bolus the patient or even start pressors.
Yeah, I would say that I agree that very high hemorrhagic risk patients should have a lower blood pressure parameter. So like you said, unsecured vascular lesions like aneurysmal subarachnoid hemorrhage. I will say that like fresh post-ops, it depends. So if it's a non-trauma patient, then I'll often do less than 140. And if it's, a focal TBI that has a higher risk for hemorrhage, so like an epidural hematoma, then I'll often do less than 140 or sometimes even less than 120 if the hemostasis is difficult in the OR. But For instance, post-op TBI patients that have elevated ICP or a lot of cerebral edema, I'll often still do 160.
Exactly. Yeah.
Just because the data for increased hemorrhage expansion between an upper limit of 140 to 160 is very limited.
Yeah.
At least in a post-operative and TBI patients, there is definitely, I think, pretty reasonable evidence that it's probably higher in unsecured vascular lesions. So
Yeah.
just keep that in mind, and obviously just for so everybody's aware, I'm sure they are, that the reason why we choose a slightly higher blood pressure usually in TBIs is because a lot of these patients, not only do they have cerebral edema and can have elevated ICP, but particularly severe TBI patients, but really all TBI patients have quite a significant drop in cerebral blood flow um, immediately after the trauma. So in severe traumatic brain injury, that decrease in cerebral blood flow can be anywhere between 2 to 4 times like a full drop. So in other words, it can drop in half to 1/4 of what it normally can be. And so in those first 24, and then later on, they can become hyperemic. But usually in that first 24 or 48 hours, that's when they're at the highest risk of having ischemic events related to their traumatic brain injury. So you don't want to lower it too much.
Exactly.
And the lower limit of like 110 for severe TBI, that's based upon the Brain Trauma Foundation guidelines. They used to use 90 across the board in severe traumatic brain injury. Anything less than 90 was considered hypotension, and it's become very clear that in a lot of patients with brain injury, that lower number should be higher. And basically, in severe traumatic brain injury, they showed that it should be greater than 110 for most patients. For patients between the ages of, if I remember correctly, 50 to 65, I think it was, or maybe I think it could be 105 was the lower limit, but everybody, just to make it easy, says 110. So if you're in a coma after a traumatic brain injury, then that lower limit should be 110. Again, once you have an ICP monitor in and can go by CPP, CPP is always trumps systolic in most cases, because that's
Exactly.
really, that's the whole reason we're doing these SPP parameters, is to ensure, adequate cerebral perfusion of the lower number. So
Yeah.
one could argue that in a reality, what the ideal scenario is, that if you have an ICP monitor in, that you should go with CPP for your lower number and then systolic potentially for your upper number. But as you mentioned, due to the way Epic is designed, or EMRs are designed, and the way the Joint Commission works and stuff like that, to avoid confusion, that you have to have your lower and upper limit should be the same
Yeah.
parameter.
And we can still create actually a secondary goal, but even if people
Yeah.
have told us no, you cannot put two different orders, but we could use that word, which I think you created in the ENLS or the Elmer's neurosurgery smart phrase, that the primary goal is CPP 65 to 85, and a secondary goal would be a systolic below 160. It does make sense, but there's also data that indeed a CPP above 85 or 100 in most patients will trigger some cerebral edema. So that's why, yeah, even if we don't say 160, basically what we have in mind is a CPP that is too high will be detrimental. So yeah, that's only one slide, and but I can spend an hour debating that, and I welcome the debate of pros and cons. As I said, with maybe anesthesia and vascular neurology and interventional to discuss that. But just briefly, why do I say 120 to 140 and everybody's using a template saying 130 to 150 and saying, hey, it's the AHA guidelines? I see it slightly differently because of what.
In Epic chat with the
Oh, sorry.
oncologist.
If
So
anybody
Diallo
can,
has to been so
can you mute yourself? I think on Reginald's part. So The prior AHA guidelines, as I said, were saying like less than 160 is good because by putting the bar so high, we're avoiding hypoperfusion, and there was no great data that actually being super aggressive below 140 was superior to less than 160. So then two trials also tried to address that, Interact and Attack 2, and basically one was positive, showing that less than 140 is slightly better, but overall, when you do a meta-analysis, people were saying no, it's not good to go below 140. It's because many patients less than 140 will result in a systolic that is bottoming down with a burden spent of time spent at 110 or 120, resulting in new ischemia. And that was studied by Buletko, as I said, a publication that is the only one that focused on the burden at the lower limit. And they said when you target less than 140, then the patients who had spent I can't remember how many minutes at 110 and 120 had X amount of complications. So they did systematic like hyperacute MRI and then a repeat MRI, I think after 6 to 12 hours. And they looked also at the renal function. And it is true that if you are targeting less than 140 and that results in you, unfortunately, continuing your clevidipine or nicardipine drip to the point that your patient bottoms down their systolic blood pressure to 110, you will have about 25% risk of having new DWI lesions in a scattered pattern in the hemisphere of the intraparenchymal hematoma. So it is detrimental to be too aggressive. But if you're doing a good job of doing less than 140 and like in an Interact you stay between 120 and 140, you will actually avoid those ischemic complications, whether they're cerebral or renal, and still get the benefits that Interact showed, as well as one other smaller trial. Of note, Interact and Attack never said that 150 was acceptable. All the patients that were in those trials were deemed to be too high in their blood pressure at 150 and ended up with a drip to lower. So that is why I have also an issue with this. They're using the second sentence of the guidelines of the AHA saying, hey, therefore a range between 130 and 150 is acceptable. Yes, but it's not the real target that you should have in mind, because if you say it's acceptable to be 130 to 150, then what do you do with your guy that is at 150? You start Clevy and then you turn it off right away because he reached the target. The target is not 150 or 149. The target was still less than 140, but you want to be right below 140. So we all agree that when you are doing a goal of blood pressure reduction in all comers with an ICH of moderate size, you should do a target of basically 139. But of course, those trials had to create a range of what is acceptable, but those range of acceptability should not transform into a range of actionable items in like an actionable range with an epic order, because otherwise at 130, the patient, that patient in the ICU will, or let's say 129, the patient is going to receive a bolus of fluids or even be started on phenylephrine, which makes absolute no sense. And same thing at 149, the patient will be then discontinued the Clevy drip. That makes no sense because most patients will not have a significant benefit to be reduced from 150 to 149. Anyway, I'll spend more time arguing about all that, as well as the fact that hemorrhagic transformation should not be suddenly elevating the goal of blood pressure. As we said, like if we're telling you a TK3 is goal blood pressure 100 to 140, and then suddenly they have hemorrhagic transformation and you're saying, well, now the new goal is according to the AHA guidelines 130 to 150, you're basically shifting your goals towards an elevation of the blood pressure because the patient actively hemorrhaged when you were trying to prevent the hemorrhage, you had a lower range. For all those reasons, I did talk to Gomez and Qureshi and the authors of the AHA guidelines, and they understood why the range that they created in that second sentence of the AHA recommendations actually are misleading people. And actually, Lee Schwam and others that developed the Get with the guidelines purposely avoided saying that the metrics that they're going to capture is, did you reach 130 to 150? Because actually they all agree that 150 is actually still too high, and that the real target should be less than 140, but right below 140. And the Get With the Guidelines does not tell you what is your target. Each institution is free to set their own target and report their metrics according to their own set target. So anyway, what matters is, again, we should transform what we have into the goal of MAP to salvage the patient from ischemia complication because of a too aggressive of a lowering of the blood pressure. Transform the map that you have in mind, which is probably like mappable, I mean, a CPP of 65 with an ICP of maybe 10 or 20 means that the map goal should be 85. What is the map? What is the systolic of that patient when their map is 85? That will tell me what their systolic should be. Or if you want to use Bulletco, that proved that 110 is definitely detrimental and 120 was barely detrimental, that is how you can set your goal as less than a target goal of more than 120 and the upper limit being still very tight with 140. By the way, that creates a range of only 20 points, which has been associated also with better cognitive outcome. Like when you put too wide of a range, let's say 110 to 160, like we're doing in TBI, at least in ICH and in ischemic stroke, it's been associated with worsened outcome. You don't want fluctuation with a wide range. You want a tight range. But a tight range of 10 points would be ridiculous. So you cannot say 130 to 140 because then you're always going to be outside of that range. The other thing that Qureshi and Gomez told me was like, it doesn't matter to set I mean, we should not have order sets that are basically one size fits all. Look at the collateral status on your TCDs or on your CTA, or even better, at the end of your recanalization, do a parenchymography. So that's something that I'm going to ask our endovascular team to tell us, even in the huddle. Look at the last slides and put the contrast into the maximum amount so that you see is there residual areas of the parenchyma that is not well perfused, or is everything super dark with so much contrast that went into the parenchyma that you are worried that the blood-brain barrier is open and that the patient will suffer reperfusion injury. So that could help us tweak further the goals of MAP and systolic blood pressure. Anybody on the call has done those parenchymographies or like heard our interventionalists talk about like the blood-brain barrier and how much they are worried about reperfusion injury? Is there another score that I should put there? By the way, I'll put the references. Also, Tsivgulis and Alexandrov have used that too, and Mark Rubin too, with the TCDs. So the TB score is basically the same as TICI, but they put brain instead of cerebral. It's TCDs right after a thrombectomy, and you measure the cerebral blood flow. When the mean systolic velocities or the peak systolics are so high, or the pulsatility index is so high, it tells you that you recanalize too much your patient, and now they're reperfusing so much, the cerebral blood flow will be deleterious. The neurons don't want to see twice the amount of what is a normal cerebral blood flow, and the blood-brain barrier is open. Sure enough, if you repeat the CT, you're gonna see a lot of subarachnoid hemorrhage, a lot of cortical engorgement, and that's not gonna, or I shouldn't say engorgement because it suggests veins, but hyperemia basically of the cortex, which can be measured, by the way, also on CT techniques, and that should tweak our goals of blood pressure after recanalization. So let's talk briefly also about the agents that we use. So I hope you're all familiar with all those agents and when to choose one versus another. Nitroglycerin and nitroprusside are nitrate agents that have been used quite aggressively by the cardiology world. And yes, it does really well. It does reduce the blood pressure the fastest and with the most potency. The problem with that is that nitrates are dilating your capillaries and your arterioles They can even, I think, dilate large arteries. So they're used in, let's say, exsanguination, aortic dissections, etc. The problem with us in neurocritical care is that the venous dilation that it induces is also quite bad in ICP elevation. So by reducing the perfusion of the brain and dilation, having a massive dilation of the veins in the brain, actually the cerebral blood flow and the happiness of the function of the neurons was quite compromised. So there's many reports about ICP elevation or venous outflow being compromised just by the massive dilatation of the veins, and therefore it is not a preferred agent in neurocritical care. Definitely not in TBI, definitely not in massive ICH, but you could make the case that if there is really no ICP concern, you could use it if really nothing else has worked. Hydralazine is also a venodilator and capillary dilator and arterioles dilator, so it works well and also quite fast like the nitrates. But it will induce tachycardia because of the significant drop in the blood pressure. So by reflex, there will be a tachycardia that will be seen with hydralazine, which is sometimes not desired. If you have an AFib that is already running 110 or 120 at risk of going into RVR, please do not use hydralazine. You're going to induce a tachycardia because of the drop in the blood pressure, and you're going to tip over your patient into an RVR, which will further drop the blood pressure, and then you'll be in troubles. Labetalol is our favorite medication actually because it does drop the blood pressures, although slightly less potently. It will drop a little bit the heart rate too. So if you are tachycardic, you can use labetalol. I would say between 80 and 110 or even 120 or 140, you can use labetalol that will be dropping your heart rate and dropping your blood pressure. It will drop the blood pressure more than the heart rate as compared to metoprolol. Nifedipine is really great because actually it works faster than amlodipine and the ACE inhibitors. And I think Dr. Ayala reminded me recently that we should almost go to that rather than waiting for the amlodipine to kick in whenever we're on a clevidipine or nicardipine drip. So it's true. Nifedipine is also a TID or Q8 or Q6 hour medication, and it's not long acting, so it's good because we can titrate it faster to control the blood pressure. But also, what if we overshoot and the patient develops septic shock? Then at least on nifedipine, you stop the medication and you can save your patient from profound hypotension. Versus on amlodipine or an ACE inhibitor, you will have an effect for an entire shift, and your patient may go, as I said, in septic shock, and now you have a cardiac arrest that was imputable to also your partially imputable to also your long-acting medication. And if you use amlodipine, don't use 5 milligram unless it's really a frail elderly that has been notoriously sensitive to calcium channel blockers. To me, 10 milligram is the go-to dosing. And it takes a day for it to kick in almost. As for the drips, we like clevidipine and nicardipine. They are the efficacy is about the same, except that actually you can go up to every 2 minutes instead of every 5 minutes in terms of your increments of clevidipine. So I think my next slide is showing you what the Critical Care Council is coming with, an order set that will be addressing the fact that we've been underutilizing actually our clevidipine because people are just going up every 15 minutes or 30 minutes whenever the blood pressure cuff is inflating. And I'm like, that's like buying a Ferrari and running it at 30 miles an hour only on the highway. That makes no sense. The mere fact that the medication is more expensive make use of it by being more efficient, by being at the bedside and titrating up every 2 minutes, 2 milligram increments, 2 milligram per hour increments of the clevidipine until you reach your target, and you can expect 2 millimeters of mercury to be dropping every time you do those increments. So it's easy to remember 2, 2, 2, 2. 2 milligram, you start at 2 milligram an hour, not 0.5. I know the range is 0.5 to 32, but that's just the full range of motion that you have in using the titration. But start at 2 milligrams an hour. Expect a 2 milligram drop when you increase by 2 milligrams an hour every 2 minutes, as opposed to nacardipine is 5. So start at 5 milligrams an hour, go up to 15 milligrams an hour. The increments can be by 2.5 or 5 milligrams an hour every 5 minutes, and you should reach your targets. Clevidipine is more expensive, and we're gonna maybe restrict it to neurological emergencies or even high vascular risk like unsecured aneurysms and an epidural expanding or what have you, because it's true that nacardipine is significantly cheaper. But again, I would like, at least when we do use clevidipine, people be very aggressive about it and use it the way it was devised, which was 2 milligrams an hour, increments of 2 milligrams an hour every 2 minutes to drop the systolic by 2. And then once you are at range, you can go down into minutiae and go down to like a titration by 1 milligram an hour. And when you're turning it off, it's true that you can also go down by, to 0.5 milligrams an hour if you want. Oh, labetalol is also with 10, 20, and 40 milligrams. The medication, I think it's the MCRIT. There's a podcast, and critical care physicians in the ED have been publishing the fact that we're underdosing our labetalol. Don't hesitate to use 10 milligrams. When it doesn't, when there was a partial response, basically go up to 20 milligrams, and the third dose should be 40 milligrams. When we just do 10, 10, 10, or even worse, 5, 5, 5, we're just underdosing our labetalol. And do that in parallel to obtaining your clevidipine or nicardipine drip. For those who want to remember all those different drugs, by the way, I fully spelled it out in our, I know it's too complex, but our smart phrases that I'm using for the admission of a patient to the neurocritical care team has, and you can do only this CV meds. You see there's a smart phrase 3585843 that can populate for you all those medications that we use in neurocritical care. And for the ranges in blood pressure, I've already said it there. So systolic blood pressure, you can see 140 to 180 or 140 to 200, 120 to 140, 110 to 150, or I could put 160. And I could put in parentheses preferred in TBI or when there's an ICP concern. 90 to 140 is basically goal normotensive, and a wider range like 100 to 120 when there's a like a complete liberalization of the blood pressure. For instance, when you have an aneurysm that is occluded, that is treated, now we want to let them auto-regulate or let them be auto-hypertensive so that you can pick up when they're developing vasospasm because you see the trend up in their blood pressure. The order set is coming up soon, and it will say, and that's a copy paste of my very candid discussions with multiple leaders in H&H. We should do labetalol in escalated doses. That should be the first line in our order set, 10 milligram. Then 5 minutes later 20 milligrams, then 5 minutes later 40 milligrams, and the drip then should be started. Hydralazine should be used if your bradycardic less than 50. Then the clevidipine should be used only for neuro patients, and I described above the restrictions that basically pharmacists are probably gonna force upon us. Then we can stop the clevidipine above 20 milligrams an hour and consider switching to nicardipine because of a tachyphylaxis that is often occurring. We should stipulate that it's 2 milligrams an hour increments every 2 minutes for an expected drop of 2 millimeters in systolic. And then once you're right below the target, then you can do a fine tuning at 1 milligram an hour. Clevidipine above 20, it's not the upper limit. The upper limit is 30, but it's true that above 20 should automatically prompt that we should stop and switch over to nicardipine, especially when you are on concurrent propofol, because propofol plus clevidipine together at a high rate will lead to hypertriglyceridemia. The max dose of Clevi is 32, not 20. That's in the FDA approval. So if you're not on propofol and your triglycerides are okay, and it's been only 6 hours that you've been using clevidipine, don't hesitate to go all the way up to 32. However, though, if it's been more than 24 hours or 12 hours, I like that suggestion of Dr. Hickman that maybe we should put an arbitrary threshold at maybe 12 hours. If you've been using too much clevidipine for more than 12 hours, then yes, you could be running into troubles, and maybe it's time to switch over to nicardipine. But acutely, like your patient is expanding in front of your eyes, you're within an hour of an ICH, and the patient is not on propofol, don't hesitate, go up to 32 milligrams an hour, which is the max. The run-of-the-mill choice of drip will be nicardipine instead of clevidipine, even in neurological cases, unless you have, as I said, like an aneurysmal subarach, an expanding subdural or epidural, or you have a documentation of an expansion of an intraparenchymal hematoma, then yes, you should prefer clevidipine. However, for everybody else, we're trying to use nicardipine. Start at 5 and increments every 5 minutes of 2.5 milligrams to a max of 15. If you're max on nicardipine, by the way, there should be a third line, which is labetalol drip or hydralazine drip have been used, and you can select based on your heart rate. And by 24 hours, yeah, you should make sure that if you're still on a drip, that makes no sense. You should have started already in the NG tube a long-acting medication. I think we're having issues with clevidipine used on the second day, or even nicardipine, or right now we're at a week and I have 2 patients that are still on drips, and that is why they cannot be downgraded to the stroke unit. It's because of a delay in the start of the NG tube with long-acting medication like the amlodipine or the nifedipine or an ACE inhibitor, what have you. But don't forget to place an NG tube fast and start those long-acting medications, I would say, by the hour 24. Acutely, within 12 hours, I would not be too keen on starting, because you remember I just told you, if you're starting amlodipine or a long-acting medication and then the patient develop a septic shock, now you're in trouble. But between 12 and 24 hours, please start a long-acting medications. Quickly, let's talk about phenylephrine versus norepinephrine. So now we're on the opposite side of the spectrum. We want to elevate the blood pressure. I would like our residents and PAs and students to be smart about knowing the basics of selection of the proper medication. Dopamine, vasopressin, and phenylephrine are drugs that will be vasoconstrictive versus dobutamine, milrinone, norepinephrine, and epinephrine are inotropes that will be elevating your cardiac index, make you tachycardic, and elevate your MAP. The rates in peripheral IVs versus central line are different. Obviously, all drugs at a high rate, whether it's phenylephrine or norepinephrine, are dangerous to run in a peripheral IV because they will really have a risk of too much vasoconstriction, too much necrosis even at the site of the peripheral IV. So at a high rate, phenylephrine and norepinephrine should not be used in a peripheral IV. If you do use it as a high rate, it should be only for a couple hours while you're placing your central line. That being said, the opposite is also true, that at the low rate, both phenylephrine and norepinephrine at 5 instead of 25, which is the max, should be safe in a peripheral IV. And there's no difference between phenylephrine and norepinephrine. In a peripheral IV, you can use both drugs at a low rate in a peripheral IV, and you should choose which one to use based on what is going on with your patient, which brings me to the next point. Septic shock, shock not otherwise specified. If it's hemorrhagic, obviously the transfusion or even the mass transfusion will be massive transfusion protocol will be the most helpful. In neurocritical care, in brain ischemia, in TBI, and in spinal cord injury, all those are indications where norepinephrine has been proven superior to phenylephrine. So I do not want any of those patients with those diagnoses to be started on phenylephrine unless really the heart rate is telling you that we really have an issue. They're already tachycardic at 120 or 140, or they have a recent RVR event, they're on amiodarone, and we're really worried. Then yes, phenylephrine will induce bradycardia, and that is indicated. But otherwise, you really need to prefer norepinephrine over phenylephrine. And no, it's not because the patient doesn't have a central line that we're gonna have to use phenylephrine, because I just told you the phenylephrine and norepinephrine are both dangerous in a peripheral IV at a high rate and are both safe at a low rate. So your selection should be based on what is proven to be superior. Norepinephrine is superior to phenylephrine in septic shock, shock NOS, all neurocritical care disorders, definitely brain ischemia, TBI, and spinal cord injury. Remember also that bradycardia is part of hypopituitarism, and when you have a brain dead patient or a herniating patient that is bradycardic, please do not start phenylephrine. You're going to worsen the bradycardia to the point of an asystolic arrest. So don't jump onto, oh my gosh, the blood pressure is 60 and the heart rate is 50. And I'm like, okay, well, the phenylephrine is there ready to use. I'm going to use it as a bridge to norepinephrine. No, I don't want that to happen, because if you know the physiology that your patient is in panhypopituitarism with bradycardia and you start phenylephrine, you're going to actually induce the cardiac arrest of your patient. So please do not use phenylephrine on bradycardic patients, especially neuro patients, especially panhypopituitarism patients, like brain dead patients or approaching brain death. And finally, dexmedetomidine is paradoxically sometimes elevating the blood pressure in septic shock. And I'm trying to prove that also in many neurocritical care disorders with sympathetic overtone. The reason for it is by decatecholamine, dexmedetomidine acts on the locus coeruleus, which is the biofeedback that is used to internalize your vascular bed receptors to norepinephrine or epinephrine. So for the same dose of norepinephrine, a septic shock patient is reinternalizing their vasoconstrictive receptors on their beds of their capillaries through the locus coeruleus. If you knock out the locus coeruleus with your dexmedetomidine, you start dexmedetomidine drip, instead of seeing bradycardia and hypotension, you will see suddenly a surge in the blood pressure, and you will be able to remove your norepinephrine faster thanks to your dexmedetomidine. That's called decatecholamine, and that was the substance for a phase 3 trial in septic shock. And our neurocritical care patients also benefit from that when they're in a sympathetic overtone. The proper hemodynamic augmentations is to be done by, we don't call it hypertensive, what is it called, pressing the patient or induced hypertension. No, the proper term is hemodynamic augmentation, because cardiac index matters more than the MAP. Remember that milrinone and dobutamine have a role in brain ischemia and in vasospasm. There was even trials that were showing that they work better than norepinephrine or phenylephrine. Why? It's because they're purely elevating the cardiac index. They will actually drop the MAP, and yet they will ameliorate the cerebral blood flow and the clinical exam of our patients. Cardiac index, therefore, is more closely related to the cerebral blood flow, and it does make sense. Why would you induce hypertension to 180, but then induce a reduction of your heart rate from, let's say, 100 to 80? You start me right now on phenylephrine, you're gonna augment my blood pressure from 140 to 180, but you're gonna drop my heart rate from, let's say, 80 to now 60. What is gonna happen to my cerebral blood flow? Cerebral blood flow is in milliliters per milligram of tissue of the brain by minute. So if you are pumping 180 in my brain, that's better than 140, but you're pumping it only every 2 seconds or every second now, because my heart rate is 60 per minute. I was better off actually with a blood pressure of 140, but a heart rate of 80, because the number of my cerebral blood flow was higher. It's just math by minutes, right? So elevation of the blood pressure, but reduction of heart rate makes no sense. That is also why phenylephrine is an ill-suited medication for neuro patients. The first line when you go running, when you go jogging, is tachycardia. You want to augment your muscular blood flow. You're going to augment first your heart rate. So we want basically induce tachycardia and induce cardiac index augmentation more than a MAP augmentation. Now, if along you're also driving your MAP up, then be my guest, that's even better. You're going to have your heart rate multiplied by MAP, the cardiac index that goes up, and your MAP goes up on norepinephrine, then perfect. It should be the perfect salvage. You're going to have the cerebral blood flow being significantly elevated. Milrinone's primary goal, though, is purely vasodilatory on the cerebral capillary. So in vasospasm and in RCVS, we love milrinone because it will be vasodilating. However, milrinone at a significant dose will unfortunately drop your MAP, and that is why all the protocols of using milrinone were saying you need to salvage your MAP because the cardiac index augmentation purely may be detrimental if your MAP becomes really low. So they were saying you should start norepinephrine as an early adjunct to salvage your MAP because milrinone will drop your blood pressure. And there's also the data that maybe it has a synergistic effect. You're augmenting your MAP and your cardiac index with milrinone plus norepinephrine, and you're going to significantly augment your cerebral blood flow. That being said, though, in RCVS, it's a rare disorder, but we learned that it is definitely a different disease than vasospasm. You should definitely not use phenylephrine and maybe also shy away of norepinephrine unless the MAP becomes really critically low. Because if you document, though, that your patient is MAP dependent, then yes, norepinephrine can be added to the milrinone on your RCVS patient. And remember, RCVS is also really triggered by the SSRIs and SNRIs. So those psychotropic medications should be screened and removed so that you don't worsen RCVS. Last point I wanted to make, the sympathetic overtone is not a triviality. I did just 2 consults over the last 48 hours about that. The TTM pads that we're using, those Arctic Suns, are really stimulating the skin and making patients not only shiver, but also have tachycardia and sometimes storming. Remember that when we shove a plate of chest x-ray in the back of a patient, even if people are not shoving and being gentle, it will stimulate because you're lifting up the patient and you're still having something super cold and super hard in their back. And even if the patient is comatose, you will see a surge in their heart rate, and that can trigger storming. Suctioning of the patient, even for their excessive secretions, is also unfortunately can trigger storming. So you should decrease the norepinephrine on those patients, and you should have an early resort to dexmedetomidine. Gabapentin blunts also that sympathetic overtone. Fentanyl is good, but morphine is even better because it has antihistaminic properties. And I want to remind everybody that if you have documented sympathetic overtone because the pads are still on and you're doing chest x-ray and they are in ARDS and suction and you're still using a lot of norepinephrine and no dexmedetomidine, please do not sedate my patient with midazolam because midazolam doesn't have any effects on the sympathetic overtone. I would prefer propofol and fentanyl. That is it.